Thank you very much, and welcome to this presentation on double intussusception of ileum through patent VID, which is vitellointestinal duct. To say something about where I came from, this is a city I came from. It is in Ethiopia, and it is a small city as compared to the city here in the Western countries, but it's quite beautiful with a beautiful lake beside, and also we are also home of this. The longest river in the world, that is Blue Nile. And this is the hospital I work, and we serve around a population of 10 million, which is quite a big number. And after I say this, I will go directly to my case presentation, which is about double intussusception of ileum through patent vitellointestinal duct. To say something, to say some introduction about my case. Vitellointestinal duct is a tube that connects the yolk sac to the midgut of developing embryo, and it starts to appear in the 3rd week of gestation, and it starts to obliterate by the 7th to 8th week of gestation. And in this case, I will present a case which is a double intussusception through patent VID. And this is a 31-day-old male baby that presented to our hospital after prolapse of bowel through the umbilicus of 3 days duration. And he was born from para-7 mother, and the mother didn't notice any sign of discharge from the umbilicus until 3 days of her presentation, where she started to notice the bowel to prolapse. And until 3 days of his presentation, he was able to pass stool per anus, and he has 2 episodes of vomiting of ingested matter and intermittent crying. And also, the baby has also recent history of cough of 4 days duration. And on physical examination, he was only tachycardic and tachypneic. Otherwise, there is no abnormality detected, especially on the chest and cardiovascular system and genitourinary system. We couldn't find any abnormality detected. And on abdominal examination, the abdomen was distended, and there was a Y-shaped protrusion of bowel through the umbilicus, and it is fixed to one side of the abdomen, that is to the side of the abdomen, and there was also a yellowish-green discharge from one side of the abdomen. So this is a picture of the child in the emergency department. And on careful examination of this protruded bowel, what we see was the mucosa of the ileum was visible, and it was slightly ischemic. Especially on this area. It looks more of ischemic. And in the meantime, we cover the exposed bowel with warm saline-soaked gauze, and we admit the child, we secure IV line, and also we resuscitated him with Ringer's lactate. And after that, we get consent from the patient's mother, and we take him to the OR. And this is a picture of that ischemic bowel after we apply this saline-soaked dressing, and after we do this surgical preparation. So as you can see here, the ischemic bowel was returning to viable after we apply this saline-soaked dressing while we wait for the surgery. And after that, under general anesthesia, we operate the patient through circumumbilical incision, and we reduce that double intussusceptum, and after reduction, the bowel was completely viable, except this was a patent duct which was connecting the bowel to the umbilicus. And as you can see here, the duct was the patent duct. The opening was not that it was wide. It was not. It was wide, but the bowels are not that much edematous. So after we do this reduction of the bowel, we do a resection of this segment of the patent duct together with some segment of the bowel, and we do a resection of the bowel, and we do primary anastomosis. And the child was stable after the surgery. He was transferred to Pediatric Seid, and he stayed in the Pediatric Seid for around 6 days, and we were able to discharge him. And during appointment, the child was fine. The child was completely fine. And to discuss something about the case. So as I've said previously, vitelline duct is it is also called omphallomesenteric duct. It is a tube that communicates the yolk sac to the midgut, and it starts to appear during the 7 weeks of gestation, and it appears during the 3rd week of gestation, and it will get obliterated during the 7 weeks of gestational age. But when it fails to obliterate, there are a variety of congenital anomalies that occur as a result of failure to obliteration. And the commonest anomaly is the Meckel's diverticulum, which appears in about 2% of the population. And the other anomalies are there may be a band connecting the Meckel's diverticulum to the anterior abdominal wall. And there is also another anomaly where the duct can be completely obliterated, but there will be a fibrous cord remaining between the umbilical stump and the antimesenteric border of the bowel. And sometimes there may be also a patent duct that communicates the lumen of the bowel to the umbilicus. In this case, some a stool can pass from the lumen of the bowel to the outside of the abdominal wall. And there may be sometimes sinus where the duct will obliterated on the antimesenteric side of the bowel, but this one will remain patent, so it will form a sinus, umbilical sinus. And sometimes there will be a cyst where the duct will obliterate on both sides of the abdominal wall and also on the luminal side, but in the middle there will be a vitelline cyst. From all these anomalies, this one is the most common anomaly. It occurs in around 2% of the population. And the rarest anomaly one is this one, the patent vitelline duct or patent omphallomesenteric duct cyst, or omphallomesenteric duct. And in our case, it's not only patent, but the bowel invaginates, both the proximal and distal bowel invaginates through the patent duct towards the external surface of the abdomen. So this is also another pictorial representation of what I said. So patent VID or patent vitellointestinal duct is a very rare anomaly. We couldn't find any report from our country. And the presentation, as I have said, because it is patent with the external environment, so the child usually they will start to pass meconium immediately after delivery. They will start to pass meconium towards the umbilicus, but sometimes, like in our cases, very rarely, both the proximal and distal segment of the bowel can start to prolapse, especially when they have increased abdominal pressure, as in our case. This child has cough of 4 days duration, so this cough will increase the intra-abdominal pressure that will result in prolapsing of the proximal and distal part of the intestine toward the umbilicus, and this will result in obstruction. And if this is not managed early, it will result in strangulation and sometimes gangrene of the bowel. And in our case, because it was 3 days duration, the bowel was slightly ischemic, and it was not that much grossly edematous. We do resection and primary anastomosis. This is how the mechanism of this double intussusception, how it occurs. And so, as I've said, in our case, the bowel was not edematous, so we do resection anastomosis. But there are different options of management. One can do resection and anastomosis. One can do also ileostomy if the bowel is grossly edematous, and if it's difficult to do primary resection and anastomosis, one can do ileostomy. And also, so yeah, these are the 2 options of management that can be considered. So in our case, we do resection and anastomosis, and these are the references, and also have took some references from previous case reports written in the literature, that we couldn't find any report from our country. So thank you very much for your listening.